Welcome to the presentation for Nursing 150. In this presentation, we will discuss osteomyelitis, fractures, strains, and it should say sprains. I don't know why sprains got cut off. We'll just add it here. We will also discuss vertebral disc disease in this presentation. Major concepts is related to nursing. Priority concepts related to these disease processes is mobility, pain, infection, perfusion, which means blood flow to an area, and sensory perception. So that could be numbness, tingling, loss of feeling to an area. So we'll discuss those kind of related to these disease processes. Definition of osteomyelitis is infection of bony tissue. Bacteria, viruses, or fungi can cause an infection in the bone. Invasion of one or more pathogenic microorganisms stimulates the inflammatory response in bone tissue. Infection in the bone can be extremely difficult to treat. Typically, it can be caused from an exogenous cause, which means that the organisms enter from outside the body, as in an open fracture. We'll discuss open fractures in the next few slides when we discuss fractures, and that will help you understand how basically if there's a break in a bone that breaks the skin, that is an opening for bacteria to enter the wound and then ultimately could possibly enter the fractured bone. So that would be an exogenous cause of osteomyelitis, or an outside cause of a bacteria that enters and causes infection in the bone. Endogenous means that the organism's already in the person's bloodstream, and it comes from another area. So there's bacteria in the bloodstream, comes from another area, and can infect the bone. Osteomyelitis can be an acute infection or a chronic infection, and we'll discuss that in the next few slides. These pictures here is just to kind of help you. They're a little bit difficult to see, but basically how maybe the bacteria here invades the bone, and then it can spread and cause this inflammation into the bone and cause an infection, which can be very, very difficult to treat just because it is in the bone. Just a little bit more difficult than most infections are to treat. Usually long-term IV antibiotics are required to treat an osteomyelitis. And as you can see, ultimately what can happen if the infection is not treated well, it can impact the strength of the bone and can lead to lots of complications, which we'll talk about. It's important to remember that osteomyelitis can occur in any bone in the body. So, it could happen secondary to maybe a otitis media or an ear infection that was not treated, and that can spread into the bone of the ear. Even those bones can develop osteomyelitis, so it's important to understand that this can happen anywhere. Sometimes, like central lines in a patient that become infected can also infect the bone. IV drug users are at risk for osteomyelitis due to their recurrent source of infection by injecting with dirty needles. What's listed here on this slide is the difference between the signs and symptoms for acute and chronic osteomyelitis. Chronic osteomyelitis develops in an infected bone that's either misdiagnosed or inadequately treated. So a chronic osteomyelitis may develop, especially in older adults. Inadequate care management can result with maybe they didn't get enough antibiotics or they didn't get the appropriate antibiotic for the appropriate bacteria. So you can see usually if it's an acute, they're going to run a little bit higher temperature and they're going to look more acutely ill than your patient with your chronic infection. Both will present with complaints of bone pain. So if anyone comes in and complains of bone pain, that should always be a concern. And then you're going to assess further as to whether they appear to be acutely ill or maybe it's more of a chronic illness. Taking a good health history on the patient will help you determine this as well. If they've told you they've had osteomyelitis in the past, that would make you, kind of wonder if now they have a chronic osteomyelitis. Other assessment with an osteomyelitis patient, they might have elevated white blood cells that would indicate infection. As I said earlier, they'll have bone pain. Both will complain of bone pain. They can also have an elevated erythrocyte sedimentation rate that indicates inflammation in the body related to their infection. As far as nursing care of a patient with osteomyelitis, pain management, of course, would be a key because it's going to be, as we said, it would be painful. We're going to manage their symptoms. They have a fever, we'll treat that appropriately with the appropriate medications, antipyretics for fever. Pain management. The key to non-surgical management is the appropriate antibiotic to treat the appropriate bacteria. A lot of times they will need, if possible, we will culture the area that's infected so that we can identify the appropriate bacteria so that we can treat it with the appropriate antibacterial medication. A lot of times it's long-term IV antibiotics so that we can completely get that infection treated. It's important to teach your patients about the importance of taking the antibiotics and taking them as ordered. Sometimes if they start to feel better, they'll want to quit taking it, but that they should take it the entire course that was prescribed for them. Antibiotic therapy can actually last up to about 3 months. So sometimes they have to go home with IV therapy and have home care come out and help them with that. So it's important that your patient understands that and would need education for maintaining that and calling whenever they need help with their antibiotic therapy. Surgical management may be required if antimicrobial therapy alone does not treat it effectively. It's very rare, but sometimes the wound may need, if there's a wound, it may need debrided. Sometimes the infected bone is extensively damaged, so reconstruction may need to be done. But like I said, that's pretty rare that happens. One of the major things that is the goal of the nurse and the role of the nurse with someone who has any kind of bone pain, any kind of surgical intervention for a bone injury, is to monitor that area for swelling, making sure that it's getting doing a neurovascular assessment, which means we're assessing for pain, numbness to the area. You're also assessing for circulation. So do they have a pulse to distal to that area? What's the color look like? Is it pale? Or does it look like they're getting good blood flow? What's their cap refill look like? Because anytime a bone is compromised, that can lead to an inflammatory response that can cause swelling to an extremity. That could compromise their neurovascular systems, and they could actually cause, have damage if it isn't identified early. We'll talk about that a little bit more when we talk about fractures, about assessing the neurovascular site when the patient has an area with a fracture or surgery to an area. Okay, moving on to talk about fractures. A fracture is basically a complete or incomplete break of a bone. So there's pictures in your books about all the different types of fractures that a patient may have. The bone might be completely broken, it might be splintered, it could be shattered, lots of different ways that a bone can break. Some fractures can be compound fractures, which would mean that it's an open fracture where the bone breaks so much that it can actually open the skin. Those are a little bit more serious just because of the fact that there's a break in the skin. All of our bones can be broken. There's different ways or different reasons for them, their causes. So Pathologic means that it's another disease process that has caused the fracture, which we talked about with osteoporosis and Paget's disease. That's a pathologic fracture. Overuse or fatigue can cause a fracture. A lot of athletes can end up with like a hairline fracture. One that comes to mind is runners. I've known runners who have developed a hairline fracture in their hip from overuse of in running a lot. Compression fractures is from a loading force. Sometimes it can be from a automobile accident or from like falling off and jumping off something up high. Compression fractures are a little bit more common in a patient's vertebrae, so the bones of your back. And that can develop, compression fractures can develop with osteoporosis as well, just because of the degeneration of the bone due to the weakened bone from osteoporosis. So just review these and just have an understanding of what fractures are, and really think about, as you look through these, what that means to a nurse. You know, fracture is going to cause pain, a decrease in their mobility. It can cause a sensory perception, numbness, tingling to an area, a decreased perfusion to an area, or it can cause infection. So think about what all those things would mean to us as a nurse. Pain, we need to do pain management. Mobility, we need to make sure that we're doing what we can to help them remain mobile and independent without pain. And sensory perception and perfusion, we have to do assessments on those patients with fractures. Are they getting good blood flow to the area? Are they feeling numbness, tingling? Is there good blood flow? Do they have a pulse to distal to that area that's been broken? And we'll talk about that a little bit more in class for sure. But think about, basically, when you think about fractures, we need to think about what that means to us as a nurse, what we need to do in taking good care of a patient who's had a fracture. And some of those things that we need to look for as nurses in a patient who's had a fracture is complications. Any type of fracture can have a complication that can be life-threatening if we don't identify them early and treat them early. Those complications include infection. As we talked about, it typically is more at risk in the compound fractures. They can develop an osteomyelitis, so it's important to monitor for any signs and symptoms of infection. Think about what that means to you. When you think about signs and symptoms of infection, what do you think of? You think of redness, swelling, fever, general feelings of of malaise. They don't feel good. There's swelling. There's redness to the area. Extreme pain. Maybe their pain level has gone up a lot. Signs and symptoms of infection. Elevated white blood cells. Things like that. Acute compartment syndrome can happen in a patient with a fracture. Sometimes a compartment syndrome can be a little bit difficult to understand, but just kind of think about this for a minute. In our body, we have compartments that include muscles, blood vessels, and nerves that are contained within this fascia. Fascia is inelastic, so that means it doesn't expand. So if there's swelling inside that compartment enclosed by fascia, the fascia cannot expand because it's inelastic. So the fascia that surrounds these groups of muscles, blood vessels, and nerves, when an injury occurs and there is swelling, the fascia cannot expand. So it develops this compartment syndrome. So there's like swelling inside a immovable object. So think about like a garden hose. If you put a lot of pressure in a garden hose and then you clamped it off at one end, at both ends, what happens in the middle? It's going to like get really, really swollen and have nowhere to go. Which basically what happens is this increased pressure within this compartment reduces circulation to the area and causes extreme pain, and they could actually lose a limb because it reduces the blood flow to the area, so they could actually lose it. So it's important. That's why it's important for us as nurses to check patients' neurosensory and neurovascular to make sure that they're not developing a compartment syndrome. Most common sites for compartment syndrome is the lower leg and the forearm, the longer bones typically. So to make sure your patient isn't developing a compartment syndrome, it's important to do frequent neurovascular checks. There is something called the 6 Ps. I believe those are listed in your book as far as neurovascular assessment, and that is pallor, pulselessness, gotta spell all this, pulselessness. Pain is another one of the P's. Actually, I think I spelled pallor wrong. There's 2 L's in pallor. Paresthesia, which means it's like a pins and needles sensation, like when your extremity, like if you're sitting on your foot and it falls asleep, that's paresthesia. Paralysis, so it's like they feel paralyzed. And there's this great word that they came up with. It's called poikilothermia, which means that it basically gets cool to touch. Or really talks about poikilothermia is more referring to the inability of that a limb to regulate its temperature. So if it's if you're assessing someone's arm, so if their right arm is the affected arm, and it's a different temperature than the unaffected arm, which would be your left arm, then there's poikilothermia. So it's a difference in temperature of the extremity. I think they just came up with this so that they could make it a P word as well. And it's different, poikilothermia. So basically it's temperature. It's a temperature change. So these are the 6 Ps of compartment syndrome. It's very, very important to understand these 6 Ps and know what these are in assessing a patient with a fracture, especially of the long bones. You might have heard the term VTE before, venothromboembolism. Any patient who has had a fracture, especially of the long bones, is at risk for something called a fat embolism. It's when fat globules are released from the yellow bone marrow into the bone stream within 12 to 48 hours after an injury. Like I said, if you have a patient who has had a long bone injury, like a fracture of their femur or their tibia, they're at risk for having a fat embolism, which can just like a blood clot in your leg or a venous thromboembolism, it can go to their lung and can be life-threatening. So 2 different clots that a patient with fracture is at risk for. One from the venous system and one from the fracture itself is the fat embolism. You will see that any patient where we have manipulated their bones, and some of you that might be working on the Joint and Spine Center, the orthopedic surgeons are extremely careful about prophylactically treating patients for developing clots. So it's a known thing whenever we are manipulating the bones, especially the long bones, that it really makes a patient at risk. So you'll see multiple different things put into place to prevent this. And the nurses are, it's necessary to be a nurse to understand the purpose of this so we can teach our patients. And that is monitoring them for any signs and symptoms that they've developed a clot, especially if they develop sudden difficulty with breathing, low oxygen levels that comes on suddenly. And also making sure that they're compliant with using possibly whatever the doctor's ordered as far as compression hose, the SCDs, the sequential compression devices, Sometimes they'll put them on a blood thinner such as heparin injections. So it's important for us as nurses to be able to educate patients who've had a fracture why we are doing such measures to prevent them from developing either a venous thromboembolism or a fat embolism. So just in taking care of a patient who has had a fracture, generally, initially, we usually will do a standard x-ray to diagnose a fracture, which again is usually there's no prep and it's usually pretty easy and quick to do. The x-ray may reveal a bone disruption or deformity. Sometimes CT scan is indicated to a more definitively diagnosis, but not always, but it could be an option. Because again, a CT scan is a very specialized x-ray, and that can give us a little bit closer, more detailed picture. Typically what occurs with most fractures, the first thing that the provider will do is bone reduction, or they will attempt to realign the bone for proper healing. Lots of different ways that it can be done. Sometimes it can be reduced by manually reducing it. In some cases, they will need to have surgery. This will very much depend on the type and area where the fracture is. Non-surgical management includes a closed reduction, which means they will manually reduce it. Sometimes it's by like a little traction, and we'll talk about traction in the next few slides. And then they will immobilize it. Basically, traction means kind of hooking, and I think I have some pictures, hooking a little bit of weight to the limb that can very slowly pull the bone back together. Closed reduction is the most common non-surgical method for managing a simple fracture. When applying a manual pull or traction on the bone, the healthcare provider moves the bone in so that they realign. They typically give them some moderate sedation and pain medicine for sure. The nurse usually stands by and helps in the pain management and monitoring the patient for any complication. After that, a cast may be applied in order to make sure that the bone stays aligned or reduced. Usually a specialist will apply a cast. They have to be specially trained, and it basically just keeps that bone aligned until it can heal. Lots of different material can be used for a cast. It's just important for the nurse who is there to understand what the cast is and give the appropriate instructions. Fiberglass typically is used most frequently. It typically can dry and become rigid within a few minutes, and there's waterproof and all kinds of things like that. It's just important to know so that we can educate the patients what they can and cannot do with their cast. It's always very important to tell a patient not to be scratching under a cast. They will get itchy, but they need to follow the directions that they're given for their appropriate cast and make sure that they, because they can develop infection and such if they don't follow directions correctly. The other thing to note is that it's important to make sure that the cast is not applied too tight to monitor their patient. So if it's maybe the cast is placed on the patient's forearm, we always want to monitor the part of the body that's distal to that. So that would be the hand in this case. So monitoring that hand for color, pain, swelling, loss of pulse, loss of color, things like that. Those 6 P's basically. You have to do those 6 P's when a cast is applied to make sure that it's not on too tight. They can actually develop a compartment syndrome. So with a cast, always make sure that you monitor for any signs of infection as well in case they've been in there digging under that cast and it developed a infection or anything. The other thing is traction. Traction is an application of a pulling force to part of the body to provide reduction, alignment, and rest. There's a couple different types of traction. Skin traction is the use of a Velcro boot, which is typically Bucks traction, and I have a picture of that in the next slide. It's usually secured around the affected leg. The primary purpose of skin traction is to decrease painful muscle spasms, usually with hip fractures. A weight is a pulling force. It's about 5 to 10 pounds. It's important to know in traction, when weights are involved, that they're usually not removed without a prescription. So they're ordered by the physician, and they should be left that way and not messed with until the physician says to. And it's the nurse's job to monitor the weights to make sure that they are freely hanging at all time, and make sure no one bothers them, because we're trying to help the patient heal and realign. If anybody goes and messes with those weights, it could really mess them up. We're going to talk about this a lot more in class. We're going to look at traction, and look at some pictures and things like that. Skeletal traction, there are actually screws that are surgically inserted into the bone, such as halo traction. So think about what that means. If we're taking screws and actually inserting them through the skin into the bone, there's going to be a lot more concern involved with that as far as infection. Pin site care is very important role of the nurse to do, and also to teach the patient. Some patients with fractures may need to use a cane or a crutch. Sometimes splinting is involved. So we're just going to review that in class and just make sure you understand that. Splinting may be just to help keep that bone aligned as well, if indicated. And again, we just want to make sure that it is applied appropriately and that it's not too tight. Cane and crutch use should be something that you reviewed in 121. And we'll just kind of review on how to educate a patient on the proper cane and crutch use. Here's a picture of Buck's traction, which I said is skin traction. So that means that there's just Velcro applied to this, and it's typically used for a hip fracture, and it helps to realign the hip and to decrease any muscle spasm. So with this, your nursing care is monitoring the patient's skin, because it is skin traction. And once we've hooked him up like this, there's weights. So what he's got down here probably is the weights. The patient can't get up. They can't get up out of bed. So mobility, skin are big concerns for the nurse to monitor. The other thing to and these patients that are in Buck's traction are a high priority for you on the floor. When you become on your shift, you want to check on these patients. They're a high priority to go look at, because you want to make sure that they're set up properly and that they're doing okay, because these people cannot get out of bed and they can't do a whole lot of movement because they've got a big weight hanging down here holding their leg and they can't move. The other thing with them is the weights. Just like I said, you got to make sure you look at the order and look at what the weights are and make sure that it's set up as it is ordered. Here's a picture of skeletal traction or external traction. So this is, remember we said skeletal traction is where they take pins and they insert it into the bone. Typically this is a really, really serious fracture that needs surgery. So they've had to actually place screws and traction in order for these bones to heal. Usually like a shattered bone is more where this occurs in motor vehicle accidents, things like that. And one thing I didn't mention is some terms you will hear is open reduction. Remember we said closed reduction means like if we just kind of manually try to set the bone back. Open reduction means that we had to go in and do surgery and reduce the bone, or realign it, basically is what reducing means. So you'll hear ORIF, open reduction internal fixation. That means they had surgery to fix their bone, to realign their bone. External fixation or external traction is what you'll hear related to skeletal traction. And again, can you imagine, we have to watch this person for any signs and symptoms of infection. Can you imagine how painful it's going to be? You don't see this very often anymore. Usually, like I said, the times that I've seen it was an accident, like a motor vehicle accident, when somebody's bone was very, very shattered and required surgery and pins, and it take a long, long, long time to heal. Your anterior cruciate ligament. Let me spit that out. So that's what a sprain is. It's when you pull, excessively stretch one of your ligaments that's holding the bone together, typically at a joint. And the example given here is like if you step onto an uneven surface that sprains it. A lot of pain and swelling involved. And then a strain is when you excessively stretch a muscle or a tendon. So that's strain is usually due to heavy lifting. It's a muscle pull, like when you pull a muscle, that's usually referring to a strain where you have stretched a tendon. So it's important when assessing a patient when they come in and are complaining of pain to an area like a knee or an ankle, ask them how it happened. That can kind of help you determine whether it's a sprain or a strain. If they did maybe step in a hole, it could be more of a sprain. Or if they were lifting something, or it could be more of a sprain. The key thing is that treatment is typically the same for both. The acronym of RICE is used as far as RICE meaning rest, ice, compression, and elevation. Sorry, this is hard to write these all in here sometimes. But that's what RICE means. So they need to rest it, they need to ice it, they need to wrap it to compress it and elevate it. Best way to treat both of these injuries. The problem is that some patients will do this immediately. However, the rest is where they don't follow and are compliant with treatment. They'll get back up on it before they should, and then they'll end up with pretty severe injury. So it's important that we teach them that RICE is the best way to treat it. Sometimes anti-inflammatory medications are given due to the inflammation that's caused from the sprain or strain. If it is severe, such as, like I said, an ACL tear or something like that, sometimes surgery is required, just depending. There's many, many different degrees of sprains and strains. It's important that the nurse identify, that we assess them when somebody complains of pain. Okay, how did you do this? When was it done? And get that RICE implemented immediately. Rest, ice, compression, elevation, anti-inflammatory medications if ordered by the provider. And then testing will be done to determine the type of sprain or strain that it is. And possibly surgery might be indicated, but it's really important to teach a patient to rest for sure. Back pain and disc disease are a major problem of adults in the United States. It can affect as many as 80% of adults at some time in their life. And if you think about it, we really do kind of abuse our back. Our back, especially our low back, takes a beating every day. We're carrying things, we're bending over, picking up things. And so over time we can develop some back injury or some disc disease. The lower back and the cervical neck are the most commonly affected areas for disc disease. Really the best thing to know as a nurse is that it's an important job to educate patients about the factors that contribute to low back pain, such as spinal stenosis, osteoarthritis, osteoporosis, disc degeneration, things like that. So it's important to identify those factors and to help teach them to prevent any injury from happening. Prevention of low back injury. There's some charts in your books that have some key features of that. So it's good for us to teach our patients to prevent back injury. And once they have developed a back injury, how to help manage that and how to get them back to where they are functioning and don't lose their mobility. Their pain is managed, things like that, making sure that they're still functional and that they can manage their pain. Sometimes surgical intervention is required, depending on how severe the injury is. If surgery is indicated, it's important to note what activity is allowed post-operatively. And you're also doing those typical post-operative things as far as making sure your patient coughs and deep breathes, and looking for any signs and symptoms of infection, monitoring their pain and managing their pain, administering pain medication as ordered. Sometimes they might have something that's called a PCA pump or a patient-controlled analgesia pump. That requires lots of monitoring by the nurse to make sure that the patient is getting adequate medication and pain control without getting too much. So we monitor their breathing, their vital signs very closely when they're on a PCA pump. We also monitor for the IV site that it's intact. We monitor to make sure that the medication is not causing any side effects. Some nursing safety priority listed in your book. For the patient after back surgery, inspect the surgical dressing for blood. Any clear drainage, if there's a lot of leaking of clear drainage, you might suspect that they're having a cerebral spinal fluid leakage, so that would be a high priority to monitor for. A lot of times log rolling a patient after a spinal or a back surgery is indicated. Basically, instead of turning like their back and then their legs, you're going to log roll them. So that means, and we can talk about this a little bit in class, the patient moves, you log roll them with help so that you're not twisting their back as you turn them, using a turning sheet for obese patients, things like that. So nursing priority post surgical procedure for a disc disease. Make sure you're familiar with some of the key points of that. Pain control, monitoring if they have a PCA, making sure make sure you know what they're allowed to do. If you are rolling them, you're most likely going to log roll them so that you don't put any strain or pressure on their surgical site. Monitor that surgical site for bleeding or any indications that they might have a cerebral spinal fluid leak. Some other things worth mentioning as far as disc disease and back pain is lifestyle changes can certainly help if someone is developing some disc disease. Weight reduction can always be helpful in that. The more we weigh, the more strain it is on our musculoskeletal system. So safe activity such as swimming, ways to improve their activity to help them reduce their weight can be very, very helpful in the prevention of further continuing their disc disease or having acute episodes of it. So it's important to continue to do some education for your patients who may have had an acute episode, to teach them to prevent any further acute episodes from occurring. Some lifestyle changes, of course, balanced diet, no smoking, reduced alcohol. All of those things is going to help them be healthier in general, and so that can help prevent exacerbations of any back pain. This concludes this presentation for Nursing 150. I look forward to discussing these topics further with you in the classroom and answering any questions that you may have on the nursing care of patients with these disease processes.